now I would like to take just only a second because I want to give them their full time. This is a wonderful panel. I'm going to turn it over to Cindy Leyland, who is the Paynes Casey Project Director at the Center for Practical Bioethics, for a fantastic panel. Cindy?
Thank you, Amy. Oh, we are so pleased to be with you today to talk about the value of patient engagement in comprehensive integrative pain management. I'm Cindy Leyland, and I work with the Center for Practical Bioethics, one of only 2 freestanding bioethics centers in the country. Community engagement is a core tenet of the center's work. We believe that comprehensive integrative pain management can improve the lives of millions of Americans, can save billions of dollars, and can reduce opioid prescribing. And therefore, we believe that this work is worthy of our attention. We also believe that authentic bidirectional communication cannot be understated, or overstated rather, and will greatly enhance our work together. As we heard Dr. Ben Kliegler say yesterday when he talked about the VA's whole health initiative approach, focusing on what matters to the patient is core to their whole health initiative. Our presentation today will connect those important dots in how we can change the culture and conversation and remind us how this plays out in real life settings and show improvements in patient-reported outcomes. So let's talk about how we can move the conversation from what's the matter with you to what matters to you. Next slide, please. We'll illustrate our points today by telling you about the community engagement effort of the Center for Practical Bioethics, known as Paynes KC. Paynes KC started in June 2013 in response to a funding opportunity from the Patient-Centered Outcomes Research Institute, PCORI. Long story short, we didn't get the funding. But with less than 2 weeks' notice, we thought that if we could get 6 people to join with us, we could develop a plan to respond to that opportunity. On that night in June 2013, nearly 36 people showed up, representing all colors, shapes, sizes, ages, and backgrounds. We had school teachers, financial planners, a construction worker, an organic farmer, and more. The common theme among those diverse individuals was that chronic pain had changed their lives, for all of them, and most of them for the worse. We heard stories of desperation and defeat. When we asked them to give us a one-word description of how others saw them, this was their response. Everyone in the room agreed that they wanted to change this narrative, change it from one of weakness to that of strength. Our idea was that we could establish a sustainable model to transform relationships between pain patients and those who care for them, increase access to quality pain care, improve outcomes, and reduce cost. So let's go back to that opportunity from PCORI. We had loads of data, and we knew that pain is often a pathway of loss. Loss of job, loss of home, loss of family, sometimes even loss of self. The suicide rate for those who live with chronic pain is 2 to 4 times greater than that of the general population. You'll hear more about suicide later. We also saw opportunity to effect a cultural transformation in the way pain is perceived, judged, and treated, as called for in the 2011 IOM report, Relieving Pain in America. And we decided to act upon that opportunity. We didn't get the PCORI funding, but we didn't stop working. We kept meeting with this great group of individuals and others. We met on a monthly basis. We met to talk about how we could change the paradigm, and we decided that the way forward was through education, communication, research, advocacy, and policy. Next slide, please. In September of 2015, we spent a full day together. People living with pain, researchers, the media, and healthcare providers. We had traditional biomedical practitioners, and we also had yoga and massage therapists, Reiki healers, mindfulness trainers. Do you realize how unusual that is to have all those people in the same room together for a full day? Kind of like all of us in this virtual room together. We agreed to suspend disbelief and preconceived notions and to listen to one another. We agreed upon a set of meeting norms to guide our time together. We employed a graphic illustrator to capture the energy of the day. You can see some of her work here. Next slide, please. We explored the mind-body dimensions of pain. We looked at the complementary and alternative models of pain. We looked at self-management programs, the correlation between chronic pain and sleep. We discussed the role of opioids in pain management. We tried not to leave anything off the table. And nearly 7 years later, we're still meeting. PAINS KC is an ever-evolving group of individuals who continue to learn from one another. Foundational norms, the basics you see here, agreed upon early in our existence, help keep the group grounded, as does our non-hierarchical structure. And every month, we continue to have about 24 people join us for dinner when we can meet in person, education and advocacy. Keys to our success have been building trust among the group, having a skilled facilitator, patient co-leadership, first name basis, jargon police. As you know, there are lots of acronyms in our work, and active listening. In those 7 years, our citizen leaders, as we call ourselves, have participated in educational programs for healthcare professionals and those in training. They have presented at national conferences, and they interact with policymakers, researchers, academic institutions, and the media on a regular basis. Collaborating and partnering with others is another important feature of our success, as will be illustrated by Heather Collins from the American Academy of Family Physicians and by citizen leaders Angel and Kaylin Perry. I'll turn it over to Heather, who will talk about our exciting work with AAFP, and then Angel and Kaylin will introduce themselves to you and tell you about their work with PAINS KC. Heather?
Thank you, Cindy. It's been a pleasure working with PAINS KC. I'm very appreciative of working at the American Academy of Family Physicians for the opportunity to work together. And I'd like to begin by sharing a little bit of background about my organization, the American Academy of Family Physicians. It's the national membership organization for family physicians. And family practice is at the front line of healthcare. And we're striving to move the needle on patient health outcomes for individuals and families and communities. And the AAFP works to make a difference by helping members care for patients. And that includes everyone. I've posted our mission and vision here, and you can see how patient-centric and people-centric our focus is. And so how could we begin to meet our mission and vision without patients and collaborating with patients in this work? As a matter of fact, the very definition of best practice or evidence-based practice is a three-legged stool that incorporates the clinician's clinical expertise, which is what we're supporting when we create continuing medical education activities or support continuing professional development initiatives, the very best scientific evidence available, and lastly, but very importantly, the patient's values and expectations. Evidence-based practice, best practice is at the intersection of these elements and includes the patient's predicaments, their rights, and their preferences. So next slide, please. Functioning as a team and putting the patient at the center of this work doesn't just happen spontaneously. It takes a concerted effort, and we believe that patient-centered care begins with patient-centered education. Education, preparation, and collaboration are the key. So at AAFP, I'm leading an initiative to incorporate patient engagement in all of our educational activities, anywhere applicable, and possible. And we give in those activities patients the title of faculty to give them the same status and put them on par with the physician faculty whom they partner. And we ask everyone involved in our education, our staff, our faculty, and our learners to ask themselves in our education, how might care change if the perceptions, the priorities, and the values of the patient were prioritized and put first? So patient-centered perspectives are often a missing piece of information sharing and problem solving in healthcare. And patients live every minute for weeks, months, or sometimes years or lifetimes with their conditions, and we need that expertise. They bring it to the table. Additionally, their intimate experiences with clinicians and their function as recipients and observers of the healthcare system can provide valuable feedback, if we care to listen, for problem solving and process improvement. Their input it benefits many areas. So let me kind of share a few with you and detail what that looks like. Well, first of all, patients themselves benefit. Many teach because they want to give back to healthcare or help fellow patients. And they're empowered and valued when they're asked to contribute to education and to practice change. Participating in the learning process, they are taking an extremely proactive role in their own care, and they're building bridges of communication between providers and themselves that will hopefully extend beyond the classroom into the exam room and treatment rooms. At a macro level, we're hoping to create a systemic culture shift toward patient-centered interprofessional care. And we've got a long way to go, but there's been concerted inertia in this area recently, and progress is really exciting to watch. Patient engagement makes a difference for educators and organizations like mine that want to create meaningful, impactful, continuing medical education. Continuing education, professional development, whatever you want to call it. Patient engagement is a proven educational tool that makes learning more relevant, more meaningful, not hypothetical, and ultimately more effective. Patient engagement faculty tell us what matters to them and what content needs to be covered. They help us fill in our blind spots. And they also ensure that activities meet real world needs and include the diversity of a community. So, I'd like to share for you a short video from our adult fall medicine course where two patient engagement faculty and Dr. Carter, our clinical faculty, had a conversation about some extremely important needs for chronic migraine patients. And Kaylin and Angel are the presenters here, my co-presenters, and we're just going to hear a little snippet of this classroom. So we can go ahead and play that if it's possible.
Just never giving up.
Right.
Just having that positive attitude. I know you didn't mention it. I know we've talked before, but you know, it's a real thing that people that do suffer with headaches or chronic pain, suicide is a forefront.
Mm-hmm. Yeah, because you definitely told me you struggle with a lot of depression and through this because it was so really disabling for you that you couldn't lead a normal life.
Yeah, so.
Yeah. On top of what you've gone through with the injury.
Yeah, just being able to have that open communication with your doctor or your team of doctors is the key important thing, because I know I got told a lot. It was all in my head, and I'm like, yeah, you're right. You're a genius. It is in my head.
Yes, that is in fact what hurts. Yes, thank you.
Yes.
And when this all went on, Kaylin was at age 26, so she was an adult, and there were HEPA issues.
Right.
As parents and caregivers for her, we really struggled with getting through that to some of the medical providers before we were able to get power of attorney and some legal things settled, because she wasn't functioning.
Right.
And so, having a primary care doctor that knew her for many years prior and also knew our family was very helpful in that regard. So letting those family members in and checking on what that support system is like, I thought was a big component. I know a lot of people don't have what we had in that respect with our family care provider, but kind of be open to, finding out what's going on or getting those appropriate papers signed so you can get care. Because had Kaylin not had us in the picture, I mean, even just setting appointments, getting her to appointments, we wouldn't have known. She wasn't comprehending the information when she went into appointments because she was in enough pain. So those are pretty important factors when seeing patients with chronic pain, is what's their surroundings like, who's around them.
So that, again, that emphasis for our specialty of really thinking not only about the patient, but the situation and larger context in which the patient lives and their family unit and the support and the impact.
So he talks very quickly, but there's a palpable difference in the room when patients share their needs, when patients come forward. Learning becomes immediately relevant and visibly urgent. And learners in our CME sessions have shared that these are some of the most impactful moments of their experience. It's extremely important. And that urgency to learn from and with patients to increase clinicians' knowledge and to find answers together to extend what that evidence circle looks like is at the heart of this Venn diagram for best practice. And when all these elements come together in education, learners are prepared to make a difference in practice. And that's why we're doing this. That's why I'm passionate about what we do and appreciative of the collaborations that are built with our partners. So we're going to now hear from Caitlin and Angel Perry to hear from patients themselves.
I'm Kaylin. I was a 26-year-old, fun-loving, sports-playing EMT with a dream. Just another day at the station with a pup. We got a call that would be life-changing. A guy was high on PCP. I was injured, and it would be months before I just knew how badly I was. After the accident in April, that summer was brutal. Things were off. I went to my primary care at the time. His diagnosis, Kaylin. You're tired. You have a high intense job. And last but not least, it's all in your head. Things were getting harder to process. Easy tasks became challenges. Thought to myself, maybe I am a little crazy. Because in this field, you gotta be. Fall of 2012, got another call and we were loading up our patient. I had kicked the bumper down. Just as quickly, it had popped back up. Without my knowledge, I'd fallen, hitting my arm, shoulder, head, neck, and back. After that, everything I'd ever known would be judged, disputed, and one hell of a fight. Just like a light being switched, so is my brain. Hello, 3.5 months in the hospital, where my character was questioned by my treating physicians, my coworkers, and my insurance provider. This dream at 26 just became a nightmare at 27. It wasn't until we were referred to the Diamond Headache Clinic in Chicago, I had finally felt hope and a sigh of relief. My docs in KC had given up. I had met with Dr. Diamond, and she quickly looked at me admitted me to the hospital where an entire floor was dedicated to the headache pain management care. If only there were more centers like this available, the amount of stress that would be relieved and even more lives saved. Traumatic brain injury and what I called suicide headaches were now being treated. Biofeedback, nutrition therapy, and so many more. If my providers wouldn't have been so quickly to dismiss and misdiagnose earlier on, I wouldn't have thought about suicide daily.
Hi, I'm Kaylin's mom, Angel. We were wowed by the integrated treatment that Kaylin received at the Diamond Headache Clinic in Chicago. In the intervening time since that treatment at Diamond, we've spent years struggling to maintain that care plan through the spiral from full coverage insurance to being uninsured to Medicaid and gaps in between. Each change involved interruptions to her care, forced changes in mental health counselors, renewed fights to keep consistent dosage, quantity, and brands of prescriptions, and wait times to access specialists stretched out 6 weeks to 8 months. This was overwhelming for us. And it often left me asking what you fill in the blank. Then in 2016, I was diagnosed with 2 types of unrelated cancer, an aggressive bladder cancer and stage 3 triple negative breast cancer. I was reeling again. This time it was because of the speed and access to follow up with specialists, a clear treatment plan from the outset, the access to comprehensive therapies, genetics, nutrition, massage, exercise, psychological counseling for me and my family, the coordination of my care across 3 different medical systems. I was wowed. There were and are many options for integrated cancer care in my local area that I still utilize today. For Kaylin, we had to drive a very challenging 9-hour trip when she was not functioning or processing in a normal capacity to get integrated inpatient care. This model still is not available in the Kansas City metropolitan arena. We are not here to disparage doctors or care received. We each have great care teams. Without their care, we would not be here. We just want to invite you into our lived experiences to highlight gaps that still exist for people with chronic pain in the current care models. We want all persons seeking treatment to experience wow care.
It wasn't until I was introduced to Pains KC and the Center for Practical Bioethics and the AAFP in my life that I learned how powerful and strong my voice is. Through all these amazing people, I feel like Robin Hood. I take the knowledge in my voice and I use it for the common good of the people who are suffering, the people who are providing, and the students that are learning. At the end of the day, I am one voice backed by so many courageous people. Our mission is together in our communities throughout the nation. We are citizen leaders and our voices will be heard.
You could hear the passion in Kaylin's voice, couldn't you? Pains KC believes that comprehensive integrative pain treatment will improve the lives of millions of Americans, save billions of dollars, and reduce opioid prescribing. And I need to add, when appropriate, opioid prescribing is an appropriate tool in the whole toolbox of comprehensive integrative pain management. We must move the conversation from what's the matter with you to what matters to you and improve access to comprehensive integrative pain management and communication about it so that it's available to all. We appreciate being with you today, and we know that with your help, the narrative about people who live with chronic pain can move to that of strength, perseverance, and courage. Amy, do we have time for a couple of questions, or would you like us to wait and do those after the fact?
You do have time. You've got 5 minutes left, so you're good.
Well, I see that one of the questions was about our tagline that about comprehensive integrative pain management will improve the lives of millions of Americans, save billions of dollars, and reduce opioid prescribing. I mention that because that is a positive outcome. People who live with pain, many of them don't want to take opioids because there are negative effects about that. Opioids are powerful drugs, and we would prefer not to have to take them. But we don't want to be deprived of that benefit. And many of our people say, if you can offer me something that will be as effective and help me with that, sure, I'm happy to do that. But don't just tell me, no, you can't take opioids, and say, you know, if you would just think more positive, you wouldn't need to take these opioids. That's not an appropriate answer. So we're not saying take the opioids away. We're saying include them in the toolbox and allow us to have those. We have to find out what's the right dosage for the right person and do it appropriately. I see another question is, what do you see as some of the roadblocks to get this concept accepted mainstream? One of the roadblocks is reimbursement. And I think the models that we saw yesterday from Vermont and the University of West Virginia are miles ahead of where we are right now. But reimbursement is one of the main roadblocks that I see. And I would welcome comments from other presenters yesterday. I see another question, how can we replicate this across the country? When we started Pains KC, that was our idea, that we wanted to have Pains KCs all across the country. And I'm happy to talk to anybody about how we can replicate this across the country. And as I said, keys to our success have been having a skilled facilitator. And I will tell you, it's labor intensive. It's about building relationships. Kayland and Angel, I would invite you to chime in here. How would you suggest that we could replicate this across the country?
I think just reaching out to the community, you know, starting, even if it's small in churches and community groups, and that's kind of hard in these times right now. But if you let the practitioners know, we came to Pains KC because one of Kaylin's counselors started just a test group with about 5 or 10 people in their office that they met after hours. And then that group was invited to move on into the Pains KC group. And we have been with them since that time. I initially started going because Kaylin was unable to drive herself, but I felt that it was such a need in the community that I have stuck with it.
And then you want to have a say, and you want to be part of that movement. Like I've said all along, I'm just this little ripple in the ocean, but I'm not going to stop just because I'm in the middle of a huge body of water. I want us to change the way that pain is treated and perceived. Like, let's start here today, and let's be together, that little ripple. And with one little ripple, you guys, we can change this. Like, let's do this right here, right now, especially during these times.
Absolutely. Heather, one of the questions is, what is one thing that we recommend to practitioners, especially young in practice, to be better listeners to patients in pain? Would you have an answer to that, particularly if they're family practitioners?
That's a really good question, and you know, it's really comprehensive. I think there are many ways to answer it, but one way I believe is to plug into the education and information about interprofessional patient-centered care and practice, and the techniques and strategies for doing that. It doesn't, as I said in my presentation earlier, it just doesn't come it doesn't come spontaneously. It doesn't just poof appear. there are techniques and programs and approaches that one can learn to begin to do that. And you know, Team Steps from is a system that does that, and of course at the AAFP, plugging into continuing medical education, where we're highlighting some of the ways, and you can hear from fellow practitioners and those that have been in practice for a long time that are doing it. I saw on the question list here that there was a physician who had been referring patients and caring for patients for 40 years. For 40 years, where was that? I'm trying to put my finger on it. And sending them to rehab facilities and collaborating with others to care for patients with chronic pain. And so you can listen to peers who have that type of experience when you engage in professional development.
Yeah. Mm-hmm. And I, you know, we're painting a rosy picture today because we do feel like we've had good success. But one of our citizen leaders has put in a comment that he was in the hospital after having his leg amputated, after years of living with unrelenting pain, for which he had done everything. I mean, his story could be a presentation in and of itself. And 2 days after his surgery, the first thing out of the doctor's mouth was, "We need to reduce the amount of pain medication you're taking," which was a totally inappropriate comment. So we have not achieved the success we would like to. We haven't educated every provider in our metropolitan area. We have a lot more work to do. But I do believe that we are seeing some success, and that's why we are so appreciative of your time allowing us to present to you today, because patient engagement is a core element of comprehensive integrative pain management. The patient must be part of the team. And I believe that our time is up. We thank you for listening to us. And I think that we're now on a break, and we will resume at 11:50. Thank you.